Well, my name is Jenny Joseph, and I have a program called the JJ Way, which is really a program to address racial disparities in maternal child health. And the purpose of the JJ Way is simply to say that there are some ways that you can employ right away that are very easy to do, which are very cost effective to do, but can actually eliminate racial disparities. So disparities are where a mother or her baby are suffering because of their race, because of maybe class, poverty. For whatever reason, she is more at risk than her white counterpart. In my experience, Black women, African American women, African descent women suffer most, and sometimes 3 to 4 times as many Black women are at risk of dying during their pregnancy and birth, and babies 2 to 3 times more likely to die before their first birthday if they are Black or African American. We're about being in reality today, okay? Let's not pretend our way through this. Let's not be silly. Let's be really clear about what we're talking about. So we just talk about our babies dying. We know about that. We know about the statistics. And even if you don't know the statistics, you know that they're being born too soon. They're being born too small. You know that they're being born too sick. They're not making it that first year. And recently we started talking about the women. About time, actually, right? How many years would you say we've been talking about women in terms of maternal mortality, maternal morbidity? What would you guess is the number of years that we've been doing that? Well, I don't know. Someone said forever up front. I'm thinking maybe 3 to 5 years. We're talking about it a lot. Like it's the thing, right? It was infant mortality for decades.
Yeah.
Yes?
Yes.
There's a switch. So now we're talking about the women, and we're saying it out loud, what we're saying about the women. We're saying that the women are dying, maternal mortality. That disparity has been there for decades. It hasn't changed. In fact, it's now worsening. And so I created the JJ Way model to address that. We do that by providing immediate access, unrestricted access to the prenatal care that most women are trying to find and are not able to find. We offer them quality care and support throughout their pregnancies. And we found that doing that allows a woman to find a medical home, to feel comfortable, to feel that she can trust her providers. And in that, we see that they thrive. We see that those women go full term without much problem, that those ills that pregnancy usually presents, they manage them. In fact, many of them don't have any ill health during the pregnancy.
I am COPE trained through the JJ Way. I am also an Indigenous breastfeeding counselor. I work for a nonprofit agency here in Minneapolis. I do home visiting where I follow Native moms in the community. So I follow pregnant moms and I help them to get into the care and coordinate care and get insurance. I just do many things. I am here to be part of this movement to support our moms in the community that we have here.
After the baby's born, we provide solid postpartum support as well, because that's equally important. And when a woman is supported postpartally, she gets back to normal, she gets back to being able to live her life, support her baby and her family, and to be self-determined in how she thrives as a woman. So we take care of the mother in order to take care of the baby. We address both maternal and infant health and morbidity and mortality in one program. We provide midwifery model care, whether we are midwives or not, to all women who present for that care. And in doing so, we've been able to turn the tide and literally eliminate disparities.
As a public health employee, we really have to think critically about how we authentically engage with community to really address issues around health inequities. I think there's sometimes too much emphasis on evidence-based programs, and those evidence-based programs have only been researched in certain populations, and then we try to take a cookie-cutter approach But the way to truly address the inequities and to reduce the disparities, we have to be transparent and open to really taking a ground-up approach.
2 to 3 women are dying due to pregnancy, birth, and postpartum. Don't forget the pregnancy and postpartum. The world does not revolve around the birth room. There's more to this than pushing the baby out. That's very important, obviously, but it's a day. Let's think about that prenatal course. Let's think about that postpartum course. Let's think about between pregnancies.
Like the players that was in the room wanted to be there. And so today, I'm getting in and I'm hearing about the JJ way, and I feel like I need pom-poms. I'm like, yes, not only can we say, oh, this is a possibility, this is action. This is someone who's really doing the darn thing, as we say. She's really doing it, and that gives you hope, because sometimes we all say, like, there is this possibility of this euphoric place, but no one really know how to get that road built. And she's sharing how she built her road, and I think this is awesome.
Care that where you may run into trouble, you are not on your own. Having people understand that we aren't going to be able to necessarily protect you from, but it is in your best interest to understand it from jump.
The conference today was much different because we learned a lot from the key presenter, JJ, that one of the things that we have to do is to stop talking about what we're going to do and actually do some things. And in my opinion, what I got out of that discussion and the discussion we had before, after, and during her presentation is that as people of the community, we have to overcome this linear model that we've been following for 30 years. And that is that we get a idea and we kind of go down the steps of it rather than coming together and looking at ourselves and deciding what we can do to make sure that our babies, our community is healthier.
How many nasty looks do I have to endure while you look me up and down, roll your eyes, and figure out if you can be bothered to fit me in? All of this is gone when you have no barrier to access. You just show up. What do you need? I'm pregnant. Okay, come on. Right? Now that's controversial because, oh, how do you afford it? And what do you do? Or, I don't know. We're still here.
A certain thing is like, I'm here, I've arrived, now that's it. I don't want to cause no ripples or waves. So he was like, I want to see how your experience will be, through it. So I didn't see some of that, but yeah, my background is in HR, and so once I got into the work of like really learning education of breast milk, it was mind blowing, like how amazing, just you can feed this little human being, and it's just like, I don't know, like it made me feel like I could do this.
Or other people in the community who are pregnant, I think that would be a great thing. And if we all took that on, that we're a perinatal spot of one, then it definitely can change the outcome for African American babies in our community.
Look at the way that we are servicing these families in a different way to make it so that they're coming now because they also want to, because they had the good experience, because we shaped it different and we shaped it better and we listened. And it's a whole system issue, and so there's parts that we got to work to change to make it so that when they come and they're confronted at that front desk, it can be a better experience. So that my patient who, when I saw that she was coming and I knew that she was going to be late, yes, I will see her. I don't really care what time she gets here because she went through so much at the end of her pregnancy, and the fact that I know she's coming today, I want to see her when she shows up.
Just in this last year, since school started, I've seen about 5 pregnant mothers coming to the school to get their kids. And I made the assumption that they're getting everything that they need pregnant, but I can't make that assumption. So maybe you can help me figure out a way to make where I work at the school a safe space.
So every year, look at the numbers of women that are harmed, suffering, struggling, disabled, due to being pregnant, delivering, or being postpartum in the United States of America.
that is part of our picture. That is the reality. Those are the same women whose baby drops out at 26 weeks and goes to the NICU. So here's the infant mortality piece. But let's not forget the mother is the reason that the infant mortality is the way it is. Let's have conversations today in terms of how are we really going to get through this, because we need to not only get through it but out the other end whole. And as much as this work is about moms and babies, families and communities, I want it to be about us today. Right? Let's look and figure out how we fit into this and how we can manage to be in this, how we survive being in this and get out and be whole, and our families and our communities are intact.
This summit has been really around how do we think about the different levels, the different aspects of Black birth that are really just invisible, that people don't see, that people don't have access to, that people aren't conscious of. So what I've realized being, I think for the most part, beside you, the kind of you're doing your work and being visible as a Black man in the space, like for the most part, it was me all day yesterday as in my mind as the singular Black male in the room, really studying this idea of like a Black birth summit or a Black baby summit. So for me, the idea really is about creating a space where we see the importance of Black birth continuity in terms of like mother, father, child, that there isn't a separation.
Because I work in wellness, right? But are people dying for lack of wellness? Or are they dying because of perinatal issues? I mean, they are.
It starts with, but it starts
across the continuum, right?
It starts, yeah.
But you've got, we're trying to break it into little pieces that are manageable so we can do something.
Right.
And if you did this by yourself, which you just told us you did, you came here, you're here listening, figuring it out, and in relationship to those others who are doing the exact same thing, suddenly we begin to get some useful networking that is going to stand us all in good stead. So next time you're hanging with your social worker colleagues, you could ask that question, hey guys, what are you all doing? Have you heard, have you thought? They can do even better work. As well as then they can talk with other clinics to say, you know what, we found this to be so effective, these outcomes have so improved, you might want to know the coordinating team too, and this is how we do it.
Who's doing that? The insurance companies. The insurance companies locally are
Why are they
there
doing that?
Because it's cost effective.
Thank you. So they have an agenda, but they also have figured out that you can address things to improve outcomes and get a result.
There's so much value in this room. But even like the panel yesterday, everyone on there had a doctorate or some higher level degree because they're seeing that value. And I'm like, how many births have you been at? Like, how many babies are you catching? Like, how many times have you done pro bono hours? Like, I just want to know. So, like, how do we redirect money, exposure, all those things into folks that are actually doing it, but without the access to, like, higher education or higher credentialing? And, like, really redistributing the wealth where it should be, wealth, knowledge.
Complex approach. There's not one solution. I think we have to really look at who needs to be at the table, who are the decision makers, and how many different sectors this crosses. So we're talking about the political and legislative sector. We're talking about policy level decision makers, within our institutions. We're talking about the grassroots on the ground, birth workers. We're talking about the clinics. Like, there's so many different sectors that this crosses, and so I think that it's really important for us to identify that.
Amongst all you folks who are doing great work in terms of working with mothers in our community and wanting to know and learn as much as you can so you can continue to do great work or even find new ways and better ways to do the work. So I'm going to start with Akmeri, and the question I have for you is, how do you see Minnesota moving forward in this baby safe spot?
We'll continue to be concerned about the prenatal and postpartum periods that are critical phases of development that help babies and children reach their greatest potential. And so that's going to be our main focus, and however we get that done, we're going to get that done. In doing this, we have to address families, friends, and neighbors, which is really about putting and bringing people together, doing a lot of community building. and working on having everyone feel like they're included in the process. And so really the birthing team kind of aspect, really making everyone know that they're part of the birthing team. People are birthing something through the whole process, and really having people be able to figure out what that is, what they're bringing to the table to be able to help this child to reach their full potential.
So her work is our work because it's based in culture. Everything we do, we are redesigning everything that is about what is the cultural practice for the people we work with. And the cultural practice is that we have to support her in doing this work because the mothers, the fathers, the grandmothers, and all of the people who are around this child, if they are not healthy, the child is not going to be healthy. So we've incorporated into our mission statement to unleash the power of citizens to heal themselves.
But what we want to do is how do we collaborate? How do we break down these silos? How do we stop hurting each other? One of the things that someone mentioned that we need to, within the African American community also, we need to stop feuding with each other and realize that it's not about you, it's about for the benefit of the community. And that's one thing that I really have been pushing since I've been in this position. How can we work together?
Today we are here to address infant mortality. Infant mortality has been a persistent issue in our community, and we have worked in isolation for far too long. The Black Birth Summit is an opportunity for individuals, organizations, and agencies to gather, learn, and share successes and challenges of infant mortality-related work. In addition to highlighting the work that we've been doing around infant mortality, we hope to lay the foundation to create a coordinated blueprint for a better collaboration for the future.
That executive order, the governor truly identified 4 public-facing priorities that he wants for all children in Minnesota. One being mental health and well-being, access to childcare and early education, housing stability, and healthy beginnings beginning prenatally. And really that group is mainly focused on infant and maternal mortality based on the multiple reports that I read as we were getting ready to relaunch the cabinet. There is much work that's been done that's really guiding us to that we have not seen, as our partners at MDH showed, that our numbers are changing significantly. The disparities continue to remain. So that will be a priority area of the governor moving forward.
To make any change, you have to have a theory that you work on. You need a theory of change, both as organizations and as individuals. And certainly when I was at MDH, we had a theory of change that says we're going to advance health equity. We need to organize the narrative, we need to organize the resources, and we have to organize the people. So we used a community organizing strategy. And certainly we've talked a little bit about organizing that narrative, changing that narrative. That's really important because you have to have that as sort of the base. Then organizing the resources, that's where all of the other people and all the other agencies with all the resources, we have enough money in the system, it's just not used very well. And so, as you said, we have to work with our partners and really get other sectors to work on those social determinants of health, which includes, as part of the social things, the political determinants. And then the third piece is organize the people. And that community organizing strategy. If you are not actually building community capacity in your work, you're doing the wrong work. You can build community capacity. How are you strengthening that capacity? How are you forging partnerships? When you do that home visit, how is that being used to strengthen community capacity? Not just providing a service, but building community capacity.
Talking about infant mortality in the Black community in Minnesota, and I feel as though some great solutions are if we have more hospitals, clinics, and birthing centers run by us with healthcare professionals who look like us to give us a better integrative and cultural approach to our healthcare. Because it seemed like in healthcare facilities where it's not enough people that look like us, they really can't understand, and then the racism fact can play in, and that's how the low births are happening.
The group felt like the purpose of a collaborative would be to have a political role or voice and a policy platform or statement. with really strong African American community leadership. So a collaborative would bring in big system and healthcare players and health system players to listen and be accountable to the collaborative, but it would be community leaders driving the collaborative. And then the group also talked about the importance of some state recognition for a collaborative, like an ombudsperson.
Oh, hi, I'm Atande. I work for LaCroix Consulting. I've been brought in to help facilitate some small group discussions at the 2019 Black Birth Summit. It's our chance, our opportunity to have attendees be in conversation with one another. We really want to learn and hear about how it's possible to work together to improve Black infant and maternal health. And so we're having everyone here talk about their work, what they do, how they could benefit from a collaborative, and what they could contribute to a collaborative.
And then true partners in the work? I guess you mentioned ICHR as a collective.
Yes. And that's in the work directly tied to Black maternal infant health? Okay. I would say any nonprofit that deals with any of the social determinants of health. So for instance, like the YWCA, they have a housing program. And so we work with them because oftentimes those mothers don't have health insurance and don't have a home clinic.
Each of us who need to be propped up. You know, sometimes when we're like, I'm quitting my life, I'm done, everything. So, I mean, that's one of the things too. So that is how collaborations work, I think. And I think one of the things that was mentioned today is a healing circle. And I think that intended for space is really important, and that needs to happen in the Black community. It needs to happen in my Latinx community as well. And it needs to happen in just...
Those are the sorts of things that a collaborative could do. So it becomes the people who are on the ground actually become the leadership within the context of the model. So we're not asking permission to do the practices that we know will save babies' lives, but in fact we become the authorities in what it looks like to save babies' lives, and then that gets replicated across the system. That's what the collaborative can do for us. So.
This summit is important to us because it talks about, first of all, the age of children that we serve. And infant mortality is really important in terms of homelessness. We just recently had a case where we lost a little one, a 2.5-month-old, and it was something that was really hard for us to deal with. So we are dealing with a lot of the issues that we're talking about at the summit.
In our organizations, how do we address the root cause of these inequities like social and institutional racism and social determinants of health? What things specifically did you do in your organization or work to actually highlight that and give people the courage to call those things as they are racism?
Well, I mentioned the term prevention strategist. We need to position ourselves in places where we're not always in those spaces, and it's not easy. But there's wins that happen. Last week, I talked about public works because we're constantly pushing them. They create roads, right? What does that have to do with health? Everything. Our parks department creates parks, and what does that have to do with health? Everything. When you're in your community, if you can't get to point A, from point A to point B, that affects your health. It affects your birth outcomes. It affects everything about you. So we need to be putting ourselves in those spaces in order to make those changes.
I started there in 1980 and looked at infant mortality, and it's now 2019. And in those 39 years, the African American infant mortality today still doesn't reach the white infant mortality rate in 1980. Despite all of the great medical care we have in our state, we are listed as #1 in terms of medical care, and the great public health agencies that we have doing really good public health work, and all the community agencies doing wonderful work, just listening to all of those things. Despite that, after 39 years, we've not closed that gap.
Do you just look at it with a lens, or do you start to break down to like what the real problems are, you know? And so I wonder, I'm thinking of the
preschool development grant, and tons of money that's going to this, and one of the big asks in the end is navigators to help families navigate a broken system. But it doesn't really make a lot of sense to add a new role because the structure itself is so broken and not meant to help people succeed that you have to add a whole new role to help somebody figure out how to get through there. Do you know what I mean? So that would pass like, oh, that would be an equity lens.
So there's education to be done, and there's some history that is there. We acknowledge it, and we can't take it with us. And so we got to open those doors. So you're right. Like, there's members in my family that if they would get pregnant, they wouldn't feel confident enough to go to an OB and speak about themselves.
Things I haven't heard you all talk about is Minnesota Nice. Because you can do whatever you want to do. You create all programs. That is a traumatic experience for people of color in this town. So I'm wondering, I think when I lived here, the United Way had everybody do diversity training in order to get funded. So I'm wondering how you're going to get in there with that. Okay.
I'm new here. I'm from New Jersey. I've lived in Texas. I've lived in Kentucky. And I am claiming not to be Minnesota nice. I'm not rude. I'm professional, but I am being ignorant to it. And I'm just going to stay myself.
I just came back from a week in the Mississippi Delta, and William Faulkner is from Mississippi, and he said, "What ain't believed ain't seen." And in Mississippi, they believe that racism is an issue. In Minnesota, we don't believe it, therefore we don't see it.
Who are saying that they're doing equity work, because many people who are, and that's if you're a person of color or not, I've seen it in many spaces where they're just benefiting and they're still creating harm for those that they're doing the work in the name of. And so I guess it's a question. Have you thought about that? Have you added that layer into what you're already doing? And if not, then I guess I'm making a request. Could we do that?
Yeah, that's a good question, and I'm glad that you pointed that out. I mean, I think any of us, if we got our hands on the list of people who get contracts with our big systems, you're going to see some similar names over and over and over and over again. And so what we try to do is, one, we try to ask questions that we know will get at the cultural component of what needs to be done. And those of us who experience this and have been on multiple sides of racism can read the truth in those answers. So one, we need to make sure we have the right people reading those contracts and those responses. And the second thing is, it's hard to get into our system. And so we work hard to make sure that we are looking for people that we hear are doing this work and are helping them fill out the process and fill out the paperwork and understand how you get your name in the contracting system so that you can be eligible to even get the funding. It's a game, and we have to do what we can from the inside to break down those walls for people to get on those lists.
Here, it's very specific, and so my question really is around the systems in which all of you work. How is Blackness being centered in the strategies and the results that we're looking for? How are we centering Black women, Black children, Black fathers? Really, how are we centering the Black family and the culture exactly in the tools that it requires to really reduce the infant and maternal mortality in our community?
To change how we basically credential people. And our system right now is not set up to do that. And it'll keep the people that you were talking about in that previous question out of the system, so people will go out in alternative ways. So I think the one opportunity we have is and it's a stretch, but the accountable communities for health. When you look at total cost of care, we have to start looking at a variety of different kinds of data to say what actually is making a difference in our health. It's not just the objective data, but a lot of the subjective data, community data. And so if you can eventually get at total cost of care, we will recognize that doulas and lay midwives are actually improving quality, improving outcomes, and reducing costs.
We also need to make sure that people understand the language.
because
I think that's
first
Yeah.
because there's
Shared language
and shared
definitions.
understanding.
Yeah.
Because you hear terms like trauma-informed approaches, and
It's like
I've
a
seen
hot term
one
now, right?
approach, I've seen a million approaches. Understanding the difference between health disparities and health inequities. Because oftentimes we hear people use them interchangeably, and you cannot. They are two separate things.
As much as we put the services together, it's not going to overcome the racism. So we have to figure out some way, and I don't know the answer. I mean, obviously, but it has to be called out. It has to be brought forward every single time. We've had 400 years where we have perpetuated a system that has really disadvantaged populations over and over and over again.
To hold us accountable, to keep knocking down our door to say, because I know just in the 6 months that I've been there where I've seen the politics get in the way. And I know that the folks that are here today from the Department of Health really want to help break that down. And I feel, as well as being overwhelmed today, very optimistic in seeing other states that are seeing flexibility in Medicaid dollars. We've seen North Carolina, Oregon, Ohio, places do this that are demanding different payment structures that adequately pay for other types of professionals that start to break down some of the disparities. And we know, again, the elephant in the room of structural racism and everything that needs to be done to continue to not just bring the table to you, but have food on it, to compensate you for the work, for the ideas, for everything that you guys have talked about. So I just want to emphasize my personal commitment that door is always open, that our team is truly committed to this work. I'm super thankful for everything that you guys have done, Helen. So proud, and definitely this will go in the top 2 days for me.